Onc Live Insights is a video editorial program produced by Onc Live.
So patients that would receive pomalidomide or carfilzomib and would be enrolled in a clinical trial, what's the rationale for enrolling those patients on clinical trial?
Okay, so if they are eligible for pomalidomide or carfilzomib and a clinical trial, usually it depends on the criteria for the trial. Sometimes if they have received pomalidomide or carfilzomib, they are not then eligible for that clinical trial. So we kind of tell the patient, you know, these are all these options for you, but let's try maybe the clinical trial first, and then if that doesn't work, we can then give you pomalidomide or carfilzomib, or vice versa. Sometimes having one before the other kind of excludes you from moving forward. So in general, we definitely mention the clinical trials. They will read about the clinical trials, get more information about it from our research team, enroll in, if they meet the eligibility criteria, enroll in the trial, and then if that fails, if they have disease progression on the trial, then they are then able to go on to pomalidomide or carfilzomib or some other combinations of agents. So that's the way we approach that.
So before I end our discussion today, if I could get you to comment a little bit on future directions and combination regimens that you seem to be most excited about moving forward.
So the good news is we're always excited about what's coming next, and that's what's kept all of us going. I think the next phase is going to be monoclonal antibodies. There's a couple of them already in phase 3 trials. We have elotuzumab, which targets CS1, a protein which is pretty much present on all myeloma. We're waiting on seeing the registration trial is complete now, Joe, and we'll wait to see how much adding on that elotuzumab does to the Lendex arm. We're already incorporating monoclonal antibodies like elotuzumab in certain high-risk situations in the upfront setting in multiple myeloma. The other monoclonal antibody, which is very interesting, is there's a couple of them which are directed against CD38. There's one SAR antibody, SAR, with, I don't remember the numbers, and the other one is daratumumab. There's data at this meeting with both of those antibodies. And what was interesting about those antibodies was, we are for the first time seeing single-agent activity with a monoclonal antibody. I think what's going to be, we've done work around certain antibodies targeting the B-cell receptor pathway. We've used drug antibodies like tabalumab, which we found very promising. We'd have to wait and see what the phase 2 data looks like, which is a completed trial. I do think immune strategies such as, and this is borrowing from our solid tumor colleagues, there's a lot of interest around the whole PD-1, PD-L1 pathway, and that's certainly of great interest in the myeloma community as well. This is an immune disease, but if you can then somehow attack it immunologically as well, we've been doing this for a lot of years with vaccines, etc., but that's an area which is going to be a very active area of investigation, and most of these monoclonal antibodies are going to be in combination with the existing backbone drugs or proteasome inhibitors and IMiDs. As far as newer small molecule inhibitors are concerned, again, there's some, at least at this meeting, we have for the first time now a phase 3 trial being presented with an Hdac inhibitor. In this case, it's panobinostat in combination with bortezomib, and at least the abstract shows that there is at least a 4-month PFS benefit, or close to a 4-month PFS benefit with these Hdac inhibitors. The rationale for using Hdac inhibitors is very sound in myeloma. We started out by thinking about it targeting, using proteasome inhibitors to target the proteasome pathway, but then targeting this other garbage disposal pathway called the agrosome pathway, which is really regulated by Hdacs and specifically Hdac6. So panobinostat, the study, the Panorama One Trial, is going to be reported on Monday at this meeting, and we'll have to see the details of that trial, but I think that's going to be exciting. And more so, we are now working, drugs like panobinostat, vorinostat, etc., are more pan-Hdac inhibitors. We have a class of drugs where we are looking at more selective Hdac inhibitors, so Hdac6 specific or more selective for Hdac6. There are trials with a drug called rosalinostat, if I said that correctly, ACY 1215. We're doing a lot of trials with those, and we'll have to wait and see what the future shows with those. In terms of other small molecule inhibitors, there's the AKT pathway, which we've always been interested in, and there's great interest in looking at that. We are now getting to a point where, myeloma is not as simple as CML. It's not just one genetic abnormality and you use Gleevec and, it's going to work. But we are beginning to understand the complexity of the myeloma genome. The more we look, the more we realize that we don't know, to be honest, but we are beginning to understand that there's a lot of clonal and subclonal heterogeneity within myeloma. We also know that there are certain mutations which are targetable mutations. For example, you do have the BRAF mutation. It's not as common as in melanoma, but it still exists. We also have the NRAS, KRAS mutations, which are a lot more common in myeloma. It happens in about 20% of people will have either a KRAS or an NRAS mutation, which is about 40% of patients. And again, in those folks, the MAP kinase pathway is very activated. So I do think in the future you're going to see, things like MEK inhibitors come into play, and we're going to be using more and more of these as we go forward.
So majority of our viewing audience are community medical oncologists. Can you comment a little bit on any data, emerging data, or ongoing compelling clinical trials that may be reported at ASCO or maybe further out at ASH that you've had your eye on that could be practice-changing potentially?
Yeah, so I think of the abstracts that we have at this meeting, the two most potentially practice-changing are the ECOG trial, which compared MPT versus MPR for elderly transplant-ineligible patients. I think that was a really great study design a few years ago when we didn't know which was better. I think we now know that both of them are inferior to non-melphalan-based doublets. And so in my mind, it sort of doesn't matter which is better. It turns out they're both relatively similar because both of them are inferior to non-melphalan-containing approaches, at least as we know it right now. I think the other one that's important, and probably the most important one, is the Panorama One Trial. And the Panorama One Trial is a randomized phase 3 trial of bortezomib dex with panobinostat versus bortezomib dex and placebo. And the reason I think that's important is in this trial you're going to see data that says that there's an improvement in progression-free survival by over 4 months compared to the control group of bortezomib dex. And there's a pretty strong hazard ratio that's associated with that. And in fact, it appears to be very active in patients with high-risk myeloma. The reason I think this is practice-changing is this trial, we hope, will enable FDA approval of panobinostat in myeloma. And so I think that's an important thing to know because that's going to be another drug we have in our armamentarium to treat patients over time. Down the road, we got some hints of it at this meeting, but probably more data at ASH, will be the antibodies. And the antibodies are data that I think we're all very, very excited about. We know that daratumumab and the Sanofi antibody SAR are both very active as a single agent. They seem to be better when you add lenalidomide to them. And you put that on top of the data we already know with elotuzumab and lenalidomide and dexamethasone. And I think we're about to potentially really make big changes in the way we approach myeloma in the induction, in the consolidation, and in the maintenance phase. And all of these hopefully will result in a higher fraction of patients being cured.